Hello, my name is Jennifer Chan. I'm a medical oncologist at Dana-Farber Cancer Institute, and I'm happy to be part of today's meeting, focusing on navigating various aspects of care with neuroendocrine cancer, including various therapies. My talk will focus on navigating targeted therapies and PRRT. And as an overview of some of the topics that I'll cover, I'll focus on what targeted therapies and what PRRT is and how these agents work. I'll also focus on the outcomes and side effects associated with these therapies and when we consider using these treatments as part of the treatment plan. Peptide receptor radionuclide therapy, or PRRT, and molecularly targeted agents are forms of systemic therapy. You heard earlier today about somatostatin analogs and chemotherapy, which are also a form of systemic therapy. And these essentially are drugs that enter the bloodstream to treat cancer cells that are located throughout the body. In contrast to surgery and other local therapies like liver embolizations or ablation or histotripsy, systemic therapies are used to treat disease that can't be removed with surgery or can't be treated locally. And typically, this is when the cancer has spread. Systemic therapies have an advantage in that they can reduce disease burden by shrinking cancer. They can also slow tumor growth. And they also can improve symptoms that are related to disease. And this can either happen because there is shrinkage of cancer that then leads to improvement in symptoms like pain that's caused by the cancer. Or also with neuroendocrine tumors, the systemic therapies can reduce the amount of hormone that's being released. So some of those hormonal symptoms also can be improved with systemic therapy. There are various targets for treatment in neuroendocrine tumors, and these really are properties of the cancer cells or signaling pathways that drive growth of the cells. The important targets for treatment in NET include the somatostatin receptor, as shown on this slide. And you heard about this earlier today with somatostatin analogs, which also target the receptor. Peptide receptor radionuclide therapy also targets the somatostatin receptor, and I'll go into more detail about that in a few minutes. Some of the other important targets in neuroendocrine tumors include the mTOR pathway, and this is a signaling pathway that drives metabolism and growth, and the mTOR pathway can be inhibited with a targeted agent like Everolimus. Angiogenesis is the process of new blood vessel formation, and that's an important process for delivering oxygen and other nutrients to cells that support growth and spread. And there are various ways that angiogenesis can be targeted, including the tyrosine kinase inhibitors, another form of molecularly targeted therapy. I'm going to start first by talking more about the somatostatin receptor. Again, this is the target for somatostatin analogs and also PRRT. And somatostatin receptors are a receptor that is found on the surface of just over 80% of well-differentiated GI and pancreatic neuroendocrine tumor cells. They're less frequently found, but can also be present on lung neuroendocrine tumors. And the way we know that somatostatin receptors are present on tumor cells is through imaging. This includes nuclear imaging with a Dotatate PET CT scan where we can actually visualize where the tumors are. And this is an example of a Dotatate PET CT scan where you can see various darker spots that are scattered throughout the body, and these represent areas of neuroendocrine tumor. These lesions are considered somatostatin receptor positive if the uptake on the Dotatate PET CT scan is higher than the background liver. So you can see in this figure that the liver uptake is this lighter shade of gray, where the tumor is darker than that. The black spots that are kind of scattered throughout the body also represent areas of tumor. Peptide receptor radionuclide therapy enables delivery of tumoricidal doses of radioactivity to somatostatin receptor positive neuroendocrine tumor cells. And the way that it does this is that it pairs a ligand to the somatostatin receptor with a radionuclide. So I'll kind of walk you through how it works. The somatostatin receptor is present on the surface of the neuroendocrine tumor cells. And the peptide receptor radionuclide therapy includes a ligand that binds to that receptor. So that green portion of the figure is the ligand that binds to the somatostatin receptor. And along with the ligand, there also is a radionuclide that emits alpha or beta particles. And there's also a chelator that really is a cage that binds the radionuclide therapy to that ligand to make it more stable and make sure it's delivered to the target. Lutetium-177 dotatate is an FDA-approved treatment for somatostatin receptor-positive GI and pancreatic neuroendocrine tumors. And you can look at the name and see that there are various components to the PRRT agent. There's the radionuclide, which is lutetium-177. That is a beta-emitting radionuclide. The chelator, that's the DOTA part of the name. And the ligand is octreotate, so the tate. So this is the therapy that is used routinely now to treat somatostatin receptor positive GI and pancreas neuroendocrine tumors. The way that it works is that the lutetium-177 dotatate binds to that target, that somatostatin receptor that's present on the neuroendocrine tumor cell surface. It's internalized, and once inside the cell, it releases radiation that causes tumor cell death. As mentioned, lutetium-177 dotatate is approved for treatment of somatostatin receptor-positive GI and pancreatic neuroendocrine tumors. It's typically administered once every 8 weeks for 4 treatments, and this can be given either with or without the usual monthly somatostatin analog therapy. It's approved to be given with monthly somatostatin analog therapy, although it doesn't necessarily have to be. What's important is that amino acids are given with treatment to protect the kidneys. And after treatment, there are radiation safety precautions that need to be taken, including minimizing exposure to other people during that, especially first week after treatment, and also, making sure that body waste, especially urine, is managed. Some of the benefits of lutetium-177 dotatate are that it can slow disease progression. We have seen from clinical trials and also clinical experience that lutetium-177 dotatate can slow the progression of somatostatin receptor-positive neuroendocrine tumors. In some cases, you can also get not just the slowing of growth, but you can also get some shrinkage. And this is particularly true if tumors are higher grade or if there's a pancreas primary. In addition to slowing progression and having tumor shrinkage, lutetium-177 dotatate also can improve hormone-related symptoms. This is particularly true for carcinoid syndrome, where symptoms of flushing and diarrhea can improve with lutetium-177 dotatate. And it also can be effective for other functional neuroendocrine tumor syndromes like insulinoma or VIPoma, where the treatment can help with those symptoms caused by hormone excess. We do also have to be aware that there are side effects of PRRT, and I've listed some of the common ones and the ones that may not be quite as common or even just have low risk, but we need to be mindful of. And these include fatigue. Some people may also have some GI side effects that might include nausea or diarrhea. And there is, again, that very low risk of probably around 2% or less of myelodysplasia or less than 1% risk of leukemia. So when do we recommend PRRT? It's typically utilized for patients who have somatostatin receptor-positive GI and pancreas neuroendocrine tumors after progression has occurred on a somatostatin analog. It also can be utilized earlier in some cases, particularly if there's a high grade 2, where a Ki-67 index of the tumor is more than 10%, or grade 3 tumor. And this is particularly true if there's high disease burden. I will add that not everyone with a high grade 2 or grade 3 neuroendocrine tumor necessarily needs to have lutetium-177 dotatate as the first line of therapy, but it can be beneficial when there are higher amounts of disease where it can be important to achieve early disease control. Retreatment with lutetium-177 dotatate can be considered. It would be off-label therapy, but it can be considered in cases where there has been a durable benefit to that first course of PRRT. And there are various definitions that we use, but one kind of rule of thumb may be that there's at least 1 year of disease control where there hasn't been any growth after stopping that first course of lutetium-177 dotatate. Finally, I do want to add, and you'll hear more about this in some of the later talks, that clinical trials are being done to evaluate the efficacy of repeat PRRT with lutetium-177 dotatate or an alpha-emitting PRRT agent actinium-225 dotatate in patients with GI or pancreatic neuroendocrine tumors. So there will be important information that we learn from this trial about how repeat PRRT compares to other systemic therapy options, and we'll learn more about the safety of repeat PRRT, especially when it comes to hematologic or in some cases renal toxicity. I also want to add that there was a recently completed trial looking at a different PRRT agent, in this case lutetium-177 etatrietide, also known as lutetium-177 dotatate. This was the COMPETE trial that enrolled patients with well-differentiated non-functional GI neuroendocrine tumors or patients with pancreatic neuroendocrine tumors that were either functional or non-functional. And in this particular trial, there was a randomization to either this newer PRRT agent, lutetium-177 etatrietide, compared with Everolimus. The results of this trial were announced last year, and we learned that lutetium-177 etatrietide has an improvement in progression-free survival compared with Everolimus. So this agent is currently under review at the FDA, so I hope at some point soon we'll learn whether or not there's a new treatment option that we can consider. I'm going to switch gears now to talking about molecularly targeted agents for neuroendocrine tumors. And as mentioned before, there are two important features of neuroendocrine tumors that can be targeted with molecularly targeted agents. This includes the mTOR pathway that can be targeted with mTOR inhibitors, and also tyrosine kinase inhibitors that can do a number of different things, but also impact angiogenesis. So Everolimus is an example of an mTOR inhibitor that's approved for neuroendocrine tumors. This works by blocking that mTOR pathway that is responsible for regulating cell growth and metabolism. We have seen from clinical trials that Everolimus can slow disease progression, and what I mean by that is growth or spread to new areas in pancreas neuroendocrine tumors and non-functional GI and lung neuroendocrine tumors. Everolimus is a treatment that's given orally, and this is administered as tablets that are taken daily by mouth. And treatment is continued until there is disease progression or until treatment has to be stopped for other reasons. There are side effects to watch for related to Everolimus, and some of the common ones are included here, including fatigue, mouth sores. People can also develop a skin rash or high blood glucose level. There can be decreased appetite, GI side effects like diarrhea. Lung inflammation, what we call pneumonitis, sometimes also can occur with Everolimus. Swelling of the extremities and taste changes can occur. So these are side effects to watch for, and there can be important modifications in the dose or holding of treatment that can improve these side effects. Cabozantinib is an example of a tyrosine kinase inhibitor. This works by blocking multiple receptors that are on the surface of the cancer cell, including the VEGF receptor. This is a receptor that's involved in angiogenesis. Some of the other receptors that cabozantinib blocks includes receptors called MET and AXL and RET, and these also are important for inhibiting growth and spread. The benefits of cabozantinib are that we've seen again from clinical trials that it can slow progression of pancreas neuroendocrine tumors as well as neuroendocrine tumors that arise outside the pancreas. This really includes sites in like the GI tract most commonly, but also lung, unknown primary tumor sites, thymus, and other rare primary sites. It primarily works by slowing disease progression, but in some cases, and this is particularly true for pancreas neuroendocrine tumors, there can be shrinkage that is seen on treatment. Cabozantinib, like Everolimus, is a targeted therapy that's taken daily by mouth. And the side effects that are observed with cabozantinib include fatigue, diarrhea. Because it affects angiogenesis, this process of blood vessel formation, there can be cardiovascular side effects like high blood pressure. There also are effects of cabozantinib on the hands and the feet with a redness and a swelling, what we call palmar plantar erythrodysesthesia or hand-foot syndrome. Mouth sores, decreased appetite, weight loss, and taste changes also can occur with cabozantinib. And again, just like with Everolimus, if these side effects occur, doses can be adjusted, doses can be paused, and once there's recovery, treatment can be restarted. Sunitinib is another tyrosine kinase inhibitor. It is similar to cabozantinib in that regard, but it's different in that it blocks different receptors. Both cabozantinib and sunitinib block the VEGF receptor, but sunitinib blocks other receptors, including the PDGFR receptor, receptors that are called c-KIT and RET. So the benefits of sunitinib are that it can slow disease progression in pancreatic neuroendocrine tumors. It, like cabozantinib, Everolimus, involves treatment with pills that are taken daily. Some of the side effects of sunitinib are quite similar to what I mentioned with cabozantinib because they fall into that same class of tyrosine kinase inhibitors. I do want to mention that belzutifan is another targeted agent. This is what we call a HIF-2 alpha inhibitor, and this works by preventing HIF-2 from activating genes that lead to growth and recruitment of new blood vessels. Belzutifan is relevant for patients who have a germline or an inherited mutation in a gene called VHL. VHL, when there's a mutation in that, can lead to excess HIF-2 alpha, so you can block that with an agent like belzutifan. This is also effective and was approved last year for patients with pheochromocytoma and paraganglioma. Belzutifan also is a pill that's taken by mouth. Some of the side effects of belzutifan are quite unique, and they include anemia. There can be a drop in oxygen levels with belzutifan, and also shortness of breath, fatigue. Other side effects that have been observed with belzutifan include headaches, dizziness, some visual changes, and musculoskeletal discomfort. So when do we start thinking about using molecularly targeted agents? Usually Everolimus and the TKIs are used after progression on other therapies like a somatostatin analog or often after PRRT. How we choose between these different agents really will depend on a number of factors, including primary tumor site, a patient's other medical conditions that may make one agent preferred over the other. For example, patients who have diabetes, we may be more prone to think about using a tyrosine kinase inhibitor because everolimus can lead to worsening of diabetes. On the other hand, people who may have hypertension or other cardiovascular conditions, we may favor using everolimus because of the impact of the tyrosine kinase inhibitors like Cabozantinib or Sunitinib on blood pressure and other cardiovascular effects. As I mentioned before, it's important to recognize that when targeted agents are used, that doses may need to be adjusted because of side effects. It's quite common that, for example, with cabozantinib, doses need to be adjusted over time because of side effects. And in some cases, patients may also start with a lower than normal starting dose. For example, starting with a dose of 40 milligrams or sometimes even 20 milligrams of cabozantinib if there's concern about ability to tolerate side effects. Treatment with molecularly targeted agents like cabozantinib, sunitinib, everolimus, and belzutifan is typically continued until there is evidence of disease progression that warrants stopping the therapy, or if treatment needs to be stopped for other reasons like side effects. I want to just make a point that there are a number of different considerations in the management of neuroendocrine cancer. So it really is not a one-size-fits-all approach. And we do need to think about tumor-related factors. And I've listed some of the important factors that are considered as treatment decisions are being made. And this includes primary tumor location, some of the pathologic features like differentiation grade, the extent of spread, whether tumor is somatostatin receptor positive or not. For example, if the tumor does not show up universally positive on a Dotatate PET CT scan, PRRT may not be the best treatment option. The other factor that's related to tumor that needs to be considered is functional status, and that is whether or not symptoms related to hormone secretion are present. Some of the patient-related factors I've already alluded to and importantly include medical history and other medical conditions and performance status, how well patients are feeling and able to do their usual activities. Some of the other important treatment-related factors now include not just side effects, but how the treatment is administered, what's required with giving it, and that's like oral daily dosing is very different than giving something that's intramuscular once every month or subcutaneous once a month or intravenously. So we do need to consider mode of administration, schedule of administration, whether that treatment is available, and also cost. So this slide, I'm not going to walk through everything in detail, but I just wanted to kind of summarize some of the important considerations for tumor control in advanced neuroendocrine tumors across the various classes of systemic therapy, including somatostatin analogs. These, again, are really important for controlling disease progression and also improving hormone syndromes. The targeted agents are used in pancreas neuroendocrine tumors, and in the case of everolimus and cabozantinib, extrapancreatic neuroendocrine tumors, they mainly work by slowing progression. In some cases with cabozantinib, there can be some shrinkage. PRRT is restricted to patients who have somatostatin receptor positive tumors. The approval is in GI and pancreas neuroendocrine tumors, but we sometimes can consider this as off-label therapy for patients with somatostatin receptor positive lung neuroendocrine tumors. They slow disease progression, and as I mentioned before, can be associated with some shrinkage, especially in pancreas neuroendocrine tumors or higher grade disease. And you heard in the talk before me about chemotherapy and how chemotherapy works. And really, especially in pancreas neuroendocrine tumors, regimens like capecitabine and temozolomide can be important for slowing progression and achieving some shrinkage. So I'll just leave with a few parting words about navigating targeted therapies and PRRT for NET in the broader landscape of treatment. So again, TRT with lutetium 177 dotatate is often utilized for advanced GI or pancreas neuroendocrine tumors following progression on a somatostatin analog, but can be utilized as an initial therapy for patients with higher grade disease, particularly when there's a higher burden of disease that may warrant an earlier and more aggressive approach to treatment. The molecularly targeted therapies for progressing neuroendocrine tumors include everolimus, the tyrosine kinase inhibitors, cabozantinib, and sunitinib, and also belzutifan for patients who have VHL disease. Also important to recognize that treatment selection really does need to be individualized and made with multidisciplinary input. So I hope that information was helpful for you, and thanks for your attention, and I'm looking forward to the question and answer session. Thank you.